This is Building Bridges with Michael Hirschman.
Hello, I'm Michael Hirschman, and welcome to Building Bridges, that which unites us. A candid conversation about culture, democracy, and finding common ground. This week, I'm proud to be joined by Dr. Vin Gupta, a Harvard-trained pulmonary and critical care physician, public health expert, and major in the United States Army Medical Reserve Corps. As Chief Medical Officer at Amazon Pharmacy, he helped guide the company's COVID-19 response and shape its broader strategy across health divisions. He has also worked with major global organizations, including the CDC and the World Health Organization. Now at Manette, Phelps and Phillips, Dr. Gupta is leading efforts in the bringing care closer to home using technology to make healthcare more accessible and more patient-centered. He is also a trusted contributor to major media outlets like NBC News, where he brings clarity and compassion to complex issues during some of the most critical public health challenges of our time. So how do we build a system that earns trust and serves everyone? Let's start by hearing what New Yorkers have to say.
Do you feel that you trust the American healthcare system as a whole? Why or why not?
No, not at all. Absolutely not. Every time things that you need are denied, even stuff that my father needs a sleep apnea machine, and they keep denying that, or they keep giving him bogus stuff. I don't trust it at all. No.
I do not. Only because, with the way things are going now, the healthcare is extremely high, so I don't trust that they're going to bill me correctly, and I have to follow up on a lot of stuff when it happens.
I do. I don't have a reason not to. I mean, I've never had major issues, or I've never had to deal with insurance companies, pulling what they, have been pulling in the news and media. So I haven't experienced it myself, so I don't have any issues with it. But that's my personal experience. Yeah.
I have faith, but my faith is not about what is happening now. My faith is about what if it can be better and more trustful, more transparent in the future.
Dr. Gupta, I want to talk to you a little bit about healthcare in the United States. There's disillusionment. Costs are high. Access is unequal. Insurance denial. So if you were appointed as the healthcare czar for our country, what would you do to change the system?
I think a few things fundamentally to me have to change, and perhaps more than anything else, I span a few roles in healthcare. One as a communicator, one in technology and innovation, and the other, as a bedside pulmonologist. And so I see many different facets of what's working, certainly what's not working. More than anything else, I think a roundabout way of answering a question I'm going to be direct about in a second is, it strikes me that almost 60% of those between 35 and 54 years of age do not see their primary care doctor. They don't make an appointment. Their employer often provides them covered benefits to do so free of charge, but they don't feel like they need to do it because they don't feel symptomatic, and it's rational. Much of behavior is rational when it comes to healthcare consumption. I feel ill, I'm going to do a grudge purchase, which is go to the pharmacy, get my antibiotic, or go to the ER. You don't want to experience those things if it's beautiful outside and you're not feeling unwell. The problem with our healthcare system is partly behavior change. Yes, it's difficult to navigate prior authorizations, surgeries, getting an MRI, no question. Those are scarce resources. It's difficult to navigate it. But I think we have to think about, how do we engage people to do things that we'd like them to do, like get their cancer screenings, like set up a PCP appointment, when the vast majority of people do not do those basic things. We know that it's good to do it. We tell people to do it, and yet they still don't do it.
Who's got time for that? You got to spend every waking moment working, and then when you're not, you go to sleep. So who's got time to take off to see a doctor, or just spend any time that is not necessary there,
Yeah.
I think it's the lack of trust, because there were so many, incidents happening in the American health system that put people in jeopardy, and that's why they are doubting more and more every day?
Probably a mix of laziness and just not feeling the urgency. I mean, if you don't have a super urgent medical issue, especially in a place like New York where people are really busy with work and family, at that age, around 40, is where you start to have 1, 2 kids. I think things just get a little bit more hectic, probably, for just everyone's schedule.
After the age of 40, that people don't really see their primary physician as often is because they just don't feel the need to, because they've gotten the yearly checkups and they feel like it's a hassle. At least I know my grandpa didn't really like to go that much because of that.
And let me give you a few more examples, and then close the loop here. I'm on the board of the American Lung Association. Lung cancer is the biggest cancer killer in the United States and worldwide. 12% of people that meet criteria for lung cancer screening, which could save their life or extend their life, 12% of people that have covered access to a low-dose CT scan to screen themselves for lung cancer, so they meet criteria for it, it's free for them. 12% of people, of the, say, 100 people in a room that meet the criteria, have it covered, 12 of them actually take it up, they utilize it. 88 people don't do it. And then we talk about the fact that 60% of adults, young adults, don't ever see their primary care doctor. This is a problem of engagement. People do not want to experience the healthcare system because, they see unpleasant stories, they never want to be in an ER for understandable reasons, but as a result, they take those experiences and say, I never want to touch the healthcare system. And I think that is the problem. As we're making healthcare easier to access in the at-home environment, through virtual care, through at-home pharmacies, I'm hoping people say, okay, let me maybe revisit my willingness to establish care with a doc, to get my screenings, to do some basic things. But this is a problem of engagement and awareness. And I think until we crack that nut, these bigger issues will continue to simmer and burn.
Well, but so there's a large portion of the population that don't go to see a doctor.
Yep.
But on the other end of that scale, there's a portion of the conversation of the population that can't stay out of a doctor's office. They want to go every single day.
That's right.
You turn on the television and you get these ads for medications and they describe symptoms. You go online and you see all of these discussions of illnesses and diseases. Mm-hmm. And are we establishing through this media onslaught a population of hypochondriacs?
I think to a degree, yeah, you're right. I think people will do what they'll do with information overload, and the ways in which we're consuming health information is fundamentally different from just 10 years ago, 15 years ago when I went through training, where it was still you go to look up information in a textbook, where people generally speaking would still potentially consume information from quote unquote trusted resources like the CDC, that would post something on their website and then hope it would diffuse down to the masses. That is not the world that we live in anymore, exactly to your point, which is to say people generally, 1/3 of people, 1/3 of all searches on Google have some version of a healthcare intent, which is extraordinary. We're talking 1/3 of people are asking about pink eye or wellness or testosterone supplementation or you name it. That's an extraordinary number, and it's exactly to your point that they're searching for their own health information. They want to empower themselves, and they'll do with whatever that search engine spits out. That's going to be actionable information for them, whether me as a doctor likes it, agrees with it, or not. Does that then promote, in some cases, this sense of chronic not feeling well or unwell being? Yeah, sure, that's a segment. I think there's also a segment that says, I have it figured out, and I don't need a doc. I don't need to go and get my cancer screenings. And so what we've created is this sort of binary fission here where, a certain percentage say, give me more. I'm worried about everything under the sun because I'm getting all these inputs on demand by myself on my app, through my favorite podcaster, through my favorite influencer, or through my search engine. Or it's also saying to people that might have it all figured out or think they have it all figured out with, say, measles, where they can manage it at home. And that's exactly what we're seeing. We're seeing both trends. My fear is we're seeing more of the latter trend. People think they have it figured out, or people just simply not engaged in their own healthcare at all because they don't think they're symptomatic, or they think their favorite podcaster is going to help them through their wellness journey. That's not going to work.
I suspect there may be a group of people that don't want to go to the doctor because of denial of insurance benefits. We had a tragedy here in New York City not long ago where the CEO of a pharmaceutical company was killed.
Yep.
And there was an outpouring of support for this murderer, essentially, because of the frustration in dealing with these insurance companies.
Yeah. So I think two things can be true. One, insurance I'm a pulmonologist. I see patients that often, unfortunately, when they come into my ICU, half of them, it depends on the week, but anywhere from 30% to half of them will never leave the ICU. Many of them are getting some of the most expensive therapies that exist to see if we can save their life. 30% of healthcare dollars in any given year are spent in the last weeks of life in American ICUs across the country. So I operate in a world of high expense, intense medical therapies, where you hope as a clinician what I do in the best interest of my patient in front of me will be covered, that it's not going to cause undue financial hardship. You don't know in every single case if that's going to be the case, but I'm focused always on what the patient is best for the patient. Where it's frustrating for, not obviously for the patient and their family, and then also for me as the provider, is if we hear maybe outside of a critical setting, oh, your insurance is not going to cover that. Let's start with step therapy. Let's start with something that might be covered, and then if it doesn't work, the next thing, the next thing, the next thing. Your viewers, your audience, your listeners, no question they've experienced prior authorizations to some degree or have a loved one that's gone through step therapy. It's frustrating, especially when those first 3 PIT therapies are not going to work, and you want to kick it to sort of the maximum therapy up front. And so there's things that are, there's things that are changing in real time to address that. But it's going to take time. How do we automate prior authorization so that if somebody has a certain set of diseases and data on their clinical status, that we automatically can say, you know what, therapies 1, 2, and 3 are not going to work. We know that with artificial intelligence tools, for example. Let's automatically qualify them for step 4. It's going to take time, but that's happening in real time. So there's hope on the horizon. I will say on the assassination of the United Health CEO, 2 wrongs do not make a right. And in no way should I think we have a false equivalence where the moral injustices that happen in our healthcare system are somehow righted by the assassination of what was a father of a healthcare industry and a healthcare company that, yes, I think needs to be reformed. But murder is not the answer, of
Nothing
course.
justifies murder.
Yes.
But there's another debate going on right now, a recent debate that really was brought about by the new Secretary of Health and Human Resources, Robert Kennedy, about autism. And a lot of people not quite sure about what the issue is. Can you explain what this debate is about?
Well, I mean, speaking bluntly, and I think often when we speak in science and facts, I say this as somebody that's often doing public health communications. When you speak in science and facts and with candor, sometimes you're labeled as a partisan. And so I say this with the qualification that I'm not trying to be political. I'm just going to state the facts, which is to say that Robert F. Kennedy Jr., our Secretary of Health and Human Services, has a track record over 20 years of always asking why, or why not this, or why not that. In essence, creating skepticism amongst his followers on scientific facts that, frankly, scientific facts by definition are not foolproof. There's certainty levels in what we do in medicine. Within the 4 walls of a hospital, nothing is 100% known for sure. There's always confidence intervals. I think that this is the right thing to do for this patient, and I have a clinical trial that's going to back it up that says that that's the right thing to do with, say, 95% assurance that that's the right thing to do. That's how we publish papers in the scientific literature. Nothing is 100%. What he's done is he's taken the uncertainty intervals that exist or uncertainty levels that exist with every scientific or medical fact that exists in the world today. Nothing is a proven guarantee. And said, oh, well, why does that 1% exist? Something nefarious must be happening. Why does that 5% exist of unknowns? That doctor must be hiding something. Or in the case of autism, what's happening with the increased incidence of autism? And somehow causing a correlation or stating an association between childhood vaccine schedules, which have been in existence for decades, and this rising incidence diagnosis of autism. Just because two things can be true doesn't mean they're related. But what he's done is he's drawing associations and correlations sort of willy-nilly, shooting off the hip. And in doing so, from the perch of that as Secretary of Health and Human Services, it was one thing to do that as a private citizen, sort of putting this information out there. He's now doing it as the nation's most powerful health official. And all he's doing is he's alienating many of the people that look to him for leadership, like doctors. And I'll say with confidence, 95+% of doctors educated here in the United States, some of the best institutions in the world, believe in science and in facts and understand the nature of medicine is by definition has some uncertainty. We also understand what he's doing, which is manipulating data and misinforming people. So this autism link, let me come back to that. It is, many things can be true, just like we talked about with the assassination of Brian Thompson. Our healthcare system needs reform, assassination is wrong. In this case, autism rates diagnoses rates are increasing based on, say, historical trends and from 30 years ago. And also, by the way, childhood vaccines have nothing to do with the increased incidence of autism. What we've realized, just like with, say, lung cancer, is we have better ways to diagnose autism. We have better tools. Clinicians are more aware of these tools. They're asking those questions more often in pediatric appointments. My wife's a pediatrician. We have this conversation all the time. We're having these conversations more frequently. Greater awareness, greater accessibility of these tools means more screenings. More screenings means more diagnoses. That is fundamentally the case. We've also noticed, I mean, to be just like complete, maternal and paternal age at the first birth of their children has gotten higher. People are older, parents are older at the birth of their first child. That is strongly linked from a genetic perspective to rising incidences of autism. As are environmental risks like air pollution. There are plausible reasons why this is happening, and they have nothing to do with the childhood vaccine schedule or the MMR vaccine. Completely unrelated. Actually, a study was just put out today, an independent third party saying there is no link between the two. But what he's doing is he's harnessing threads of uncertainty, smashing them together, and then using the bully pulpit of the Secretary of Health and Human Services to put these questions out there. And in essence, what he's doing is making our lives harder on the front lines of clinical care.
I appreciate your answer because it's done with civility and transparency. But you're a public figure. Do you worry about the divisions in this country? And it's impossible to put politics entirely aside.
Yeah.
But taking a strong position against someone in a position of power in this country is different today than it used to be.
Sure.
Does that concern you?
No, you know, I mean, I'll say this for me, but zooming out. Why have a platform if you're not willing to call balls and strikes? And what is the point of waiting to see where the wind is blowing to then say, oh, let me speak up with conviction now? I think it's important for us, you know, those of us physician leaders out there with platforms, to calmly acknowledge what is true and what is not, and also to try to channel what he's thinking with, say, fluoride. Again, he does the same thing with fluoride. He does the same thing with autism, you know, other issues as well, where he misinterprets fundamental data. I would like to think unintentionally, but who knows? And then smashes together a conclusion that is wrong. And I think there's a way to have that conversation that can help not cast judgment on somebody that might believe him, but also say, you know what, actually these are potentially, let's redirect you and let's acknowledge what might be true. Let's also acknowledge where it's wrong and let's hopefully course correct. I think if you don't take that approach, you're only going to reach, you know, the 50% of the country. I do a lot of work for NBC and MSNBC. My goal is not just to reach their viewership, it's to reach, ideally, I think 70% of the country is reachable. And I would like to reach all 70%. I think there's 30%, perhaps on both sides of the political aisle, 15-15. that no matter what you say, you're not going to please everybody. And my intent is not to please everybody, but it is to build a majority coalition. And I think there's 70% of the country that's reachable that just wants common, rational guidance. They don't want stringent political talk. They don't want judgmental talk. And I found traction in that type of tone. I'm not, I've been doing this now for a while. The reason I keep doing it, I think the reason I keep getting opportunities to do it, is because I think there's a way you can talk about health information and these complicated topics that are controversial that is not off-putting to the majority. Are you going to reach everybody? No, but that's an absurd goal if that's sort of the goal at the outset, in my opinion.
Earlier in our conversation, you mentioned AI.
Yeah.
AI has the capacity of making a world of difference in medicine.
It does.
Pros and cons.
Well, the pro is every single year. A lot of your listeners may be surprised to learn that we have about 100,000 deaths in the United States every year because of an unintentional misdiagnosis. Somebody goes into urgent care or the ER, they get the wrong diagnosis. We treat them with maybe not the right medication, or we send them home and when they should have gone to the hospital, whatever it may be, and they end up dying. And there's a strong correlation to, gosh, if we had gotten actually the diagnosis correct up front, maybe that death wouldn't have occurred. Or if we got them the right treatment earlier, maybe they wouldn't have ended up in the ICU. Many, many examples. I'm sanguine beyond belief on the ways in which generative artificial intelligence at the point of care, in the electronic medical record or on my app, if I'm seeing a patient in front of me, can help take the data from that patient, their vital signs, their labs, their mass medical history, synthesize that in addition to sort of their subjective symptoms and what their complaint might be, and essentially work that against millions of data points in that generative AI model. Basically back saying, okay, here's the pattern that we're seeing in this patient, here's their presentation. What does this pattern remind you of from maybe millions of other patients that had a similar presentation? And we can do that pattern recognition in a nanosecond now with a Gen AI app on our smartphone app, or on our smartphone, or within the electronic record. And what does that actually end up netting us as clinicians for our patients? It allows us to give them better care. We can say, hey, here's what I'm seeing. Here's what I think's happening. Is that what's happening? And you can have a cross-check. You can have a fact check in real time for your clinical acumen to say, in fact, actually, here, maybe think about this, or no, you're spot on, Vin. That's exactly what's going on. This patient has pneumonia. Treat them with this. So in effect, we're entering a world where we'll have the answer provided to us rapidly from an encyclopedia that's precise to what is happening and basically precision tailored to what's happening to our patient. It's going to give us the answer. And I think that's a dramatic advance when I think about the impact it will have on reducing misdiagnosis, early treatment, all frustrations. I can't tell you how many loved ones I've had or friends have come to me and say, I don't know why that doc sent me home, or I feel like I have a bacteria and they sent me home without an antibiotic, whatever it might be. So many instances, all these nits and paper cuts in the healthcare experience that I think Gen AI is going to actually help us eliminate, if not completely eliminate, or at least significantly reduce. The con is, we talked about trust up front. We've been talking about trust throughout this conversation, building consensus. I still think people want a human being involved in their healthcare. They want the human touch. And I worry about a world where we're making healthcare more faceless, because I still think the most trusted messenger of health information remains nurses and then doctors, humans, not an AI nurse, and human being. And so how do we reconcile the benefits of technology to make us smarter and better, but also not go so far as to substitute what is ultimately so critical, which is the human touch?
So let's take a step down to a lower form of technology. I suspect every one of our listeners out there has gotten a solicitation for a very inexpensive body scan. Come on in for $35 and get a full body scan, and we'll tell you what you're suffering from.
Sure.
Is this a con?
I think I wouldn't go so far as to say it's a con. I think people are making money because it's compelling, and it's a profit generator. Here's an expensive tool like MRIs for the people. Pay $2,000 out of pocket. There's no insurance involved, and it promises you this very sort of compelling idea that we actually talked about in the lead up, which is for the people that might be the worried well or just, focused on longevity. They are hyper aware, the consumer for that type of product, that unlike the folks that aren't doing regular screenings, this group that is willing and can afford something like a full body MRI are hyper aware of the fact that there might be a tumor growing in their body and they won't know it until it's too late. Obviously, it may not. Obviously, it's unlikely to be happening, but they're aware of these potential hypothetical concerns. And what better way to guard against that than a regular full body MRI? And so these companies are preying on that worry, on that insecurity to say, well, gosh, well, yeah, we can scan you. Give us $2,000, we'll scan you full body as often as you want. The problem here is we don't know what to do with that data. Do I think that a bunch of stuff is going to be diagnosed? A nodule here, a small mass there, and it's going to lead to a biopsy here. Let's remove that there. Yeah, I do think that is the concern, is do we end up diagnosing a bunch of things that actually might have not had any impact on their quality of life or their life expectancy, but worried us enough on an MRI to say, well, how can we be sure that's not cancer? Maybe that's just there's masses and nodules exist throughout our body that sometimes are completely benign. And often the most harmful thing we do is sticking a needle in there or going and doing surgery saying, oh, we don't like the looks of that, we're going to remove it. For good reason, because other masses can be malignant. What am I getting at? It's just so early. It's so early to understand who is most likely to benefit from the $2,000 MRI. I don't think it's the general public. I think all that's going to do is create more worried well, more risk of, let's go do the next procedure because I didn't like that little nodule in the bottom of your lungs, which probably is meaningless. But because we don't image people with fancy scans at scale, we're probably going to detect a bunch of stuff that exists in the human body at scale that we didn't know, that ultimately probably isn't impacting anybody's life. So I worry about a world where we don't actually have a way to manage people's expectations on what to worry about and what not to worry about, because we don't know. We just don't know. And so we're in discovery mode. I think there's a group of people that a full body MRI may make sense. Let's say you have a strong family history of cancer, genetic predisposition to cancer. Maybe you have multiple underlying chronic diseases, and you're above, say, age 50. I'm making this up as we're talking about. But at a certain age point with certain set of chronic underlying conditions or risk factors, do I think maybe getting MRIs every few years could make sense, and maybe insurers would be willing to cover that for early detection? Maybe. But we're a long ways to providing that type of guidance and framework.
Everyone today is talking about wellness.
Yeah.
And I know a lot of people that are doing DNA testing to ascertain longevity.
Sure.
Is this a con?
No, I don't think any of these are cons. What I worry about is similar with the MRI, is getting genetic testing, understanding, here's 20 tests, and with those 20 tests, we can tell you your, whether or not you're on the track for healthy aging or whether we can get you to 120. Nobody can tell us that yet. We just don't know. And so do I think the way some of these things are being marketed, the marketing to me is misleading, yes. I've seen a few companies focus on healthy aging, healthy living, and all they're doing is repackaging a bunch of tests that already exist today with a set of supplements that already exist today, and just creating packaging and marketing around it and saying, hey, we're going to give you these battery tests. We're going to tell you to work out with a personal trainer. We're going to give you these supplements like collagen, other things that may or may not work. And we're going to charge you $40,000 for an Equinox membership with those set of services. I mean, it's sort of, they're building the plane as they're flying it, and they're making stuff up in terms of, why those set of tests, why those set of supplements. We just don't know at this point. The answer is we just don't know. Are those tests, if they reveal something, going to allow us to then tailor a set of supplements to allow you to live longer? No. Show me the data. Does anybody actually have data to say that this approach is data-driven and that we've proven that a certain set of genetic tests coupled with then informing what vitamins, minerals, exercise workouts, and food regimens you should be on, that we have that mapping done? No, we're still learning that stuff as we speak. So longevity wellness is all well, and I do think the intention is rooted in a belief that we're not doing things correctly today, that it's not one size fits all, that we all deserve to get cancer screenings at different cadences. None of us have the same set of risk factors for certain diseases. We all have a different risk profile. So we should all be tested and counseled differently. But we're not there yet. That process is just beginning.
Do we need more regulation over medical marketing?
It's funny you talk about regulation, because I think we're about to enter this world, they say, of deregulation. And what are we going to deregulate? Because we don't really, the things that people use more often than prescription drugs are supplements. 75% of the country is on a version of a supplement, completely unregulated. FDA doesn't regulate any of that. They have bodies and entities that do approvals and sort of do their own testing, but the FDA does not regulate another testosterone supplement or estrogen supplement coming online, being sold online. None of that's regulated. Marijuana at the state level, to some degree, is regulated and overseen, especially in places like Washington, Colorado. At the federal level, it is not regulated. A lot of people use marijuana. Less people use a prescription drug than they use a supplement. And so when I hear about this era of deregulation, I'm thinking, are we sure that we live in a highly regulated state? And to your point, do I think medical marketing needs to be overseen more? Yeah, absolutely. I agree with some of the comments that RFK Jr. has made about the ways in which pharmaceutical companies do mass marketing to the American consumer. I think there needs to be tighter regulations there. I think there needs to be smarter regulations on supplements and minerals. It's the Wild West out there. People are taking these in droves, 30 supplements and 30 pills going in your body in some cases. I've seen this from some patients. None of it is regulated. That's nuts. And absolutely, the ways in which we think and talk about these direct-to-consumer health wellness type offerings that sort of skirt the line of medical and wellness, they are full-bore medical services, and they should be treated as such, and they should be regulated accordingly. Because this longevity fad is a profit-generating business right now. It's making people a lot of money. Am I convinced that it's actually helping people and helping give us clarity on what's working and what's not, and informing clinical protocols? The answer is no, because it's not regulated.
Yeah, I've been to lunch and dinner with folks that will pull out a basket essentially full of supplements and pharmaceuticals, and I'm thinking, what is that, an appetizer or?
Oh, and I'm not saying they're wrong. The question here is, it would be wonderful for the American people and doctors and nurses and our institutions of higher learning and health sciences to understand, okay, well, great. I'm glad a multivitamin might help defray the onset of cognitive impairment. There was a great study actually just released last year. One of the first times a daily multivitamin was shown to actually potentially guard against onset of dementia. Fantastic. That was a core hypothesis. We proved it out. Great. That was one of the only studies that has ever been done to justify vitamin D, calcium, another one for, say, women at risk of osteoporosis. There's evidence around certain supplements that make a ton of sense. Let's do more of that. But you know what? The only way to do more of that is actually to do some degree of regulation. What does that mean? Regulation just basically means the government will take more of an effort to do studies. It will allow us to use NIH research funding to then actually do some of these studies. Why is that a bad thing? That's a good thing. If we help people avoid waste and direct them away from bad actors, of which there are many in the supplement space, and people hawking snake oil, I mean, that happens all the time. You and I are in media. I see it all the time. in the health media business. This or that, or hey, Vin, come talk about this. I try to stray as far away from that stuff as possible. But it's we have created the circumstances for a snake oil salesman to profit very handsomely because there is no regulation. Regulation is not a bad thing. And I think people connote that word by meaning things will be constrained, access will be reduced, prices will increase. That's not the case at all in this case.
So many of the doctors that I know are from older generation.
Sure.
And all they do is complain about the practice today.
Sure.
Too much paperwork, too much bureaucracy.
Yeah.
Wish we had done something different. Why did you get into the field of medicine?
Well, you know, channeling 25 years ago when I was a pre-med, and then 20 years ago, actually, just up at Columbia. I think we can probably see it here, like all the way back there. I can see the bridge. At the time, it was, you know, I had joined the military. The military subsidized my education up at Columbia. Now 10 years reserves in the Air Force, pretty wonderful experience. The reason I joined and was interested in medicine from my earliest sort of beginnings in healthcare was informed by a lot of my international experiences, both with the military and as just a private citizen doing global health work. And when I realized, I took a keen interest in diplomacy, international relations. I mean, it was an interesting time, and sort of transitioning from post 9/11. I grew up in the post 9/11 generation. My first day in college was actually the morning of 9/11, just 40 minutes south of Lower Manhattan. So I very much the 9/11 generation, very much sort of public service rooted. And what I saw in that sort of interesting sort of Bush into Obama era was the ways in which, you know, our hard military power was being maligned, but it was the ways in which we showed up in a soft power perspective, helping build hospitals across the world, helping to fund malaria programs, things that we're defunding right now, fluoride programs, vitamin A programs in places like Nepal. That was shaping and setting the tone for our diplomacy. That got me really interested, that health actually is a potent tool for international relations, diplomacy, communications, building a community of nations. And so it was actually sort of broader interests in global health diplomacy that got me motivated to enter medicine. And I thought I'd be spending less time actually bedside, more perhaps in policy communications. And you know, I've wonderfully had this great opportunity to do a little bit of both. And so luckily I'm fortunate to be able to be at the bedside, but then contribute to these broader conversations that I think are more vital than ever. Because I still think that how we show up in the world with a focus on health and climate is going to be critical. We've seen that more and more post-COVID. We've had a global pandemic, and now we have worsening environmental impacts from climate that are impacting our health. We need to have multidisciplinary leaders that are physicians and other healthcare leaders leading in society, because so many of the problems that we face across the spectrum have a health dimension to it. And I think we need doctors to be willing to step up, speak out, use their experience to help lead. And so that's sort of my loop.
Well, thank you very much for being with us today. It was a pleasure seeing you, meeting you, and I hope to see you again in the future. As we close today's episode of Building Bridges, that which unites us, I'm reminded of how deeply our health, trust, and collective future are linked. By fostering open dialogue about healthcare, equity, and innovation, we can build a stronger, more inclusive system that serves us all. A special thanks to you, Dr. Vin Gupta, for joining us and sharing your invaluable insights. And thank you all for tuning in today. With every conversation, we have the chance to build bridges that unite us.
This is Building Bridges with Michael Hirschman.